Welcome back, everybody. So we'll go ahead and get started with our next session here. Again, let me just quickly introduce myself. Buenos dias. My name is Martin Celaya, and I'm the Chief for the Office of Assessment and Evaluation at the Bureau of Women and Children's Health at the Arizona Department of Health Services. So as we heard from Stephanie's PPOR analysis, one of the primary risk factors leading to poor infant outcomes is no or limited prenatal care. We know not receiving prenatal care or receiving late prenatal care creates similar risk for maternal health outcomes, including death. For that reason, I'm also excited to moderate this session called Access to Maternal and Infant Health Care. Next slide, please. Today, I'm going to share with you all some of the data related to access to care. Then I will introduce our three guest speakers to talk about strategies and policies to improve this care. First, we'll hear from we have Edith Di Santo with the ADHS Office of Primary Care is going to talk about what ADHS is doing to address maternal and pediatric care deficits in Arizona. Dr. Sara Salek, who is the Chief Medical Officer for the Arizona Healthcare Cost Containment System, is going to share how Access is currently working to improve access to care for mothers and infants. And Breann Westmore, Director of State Policy and Payment for Centering Healthcare Institute, is going to share what is happening legislatively at the federal and state levels related to access to maternal and infant care. But I'm first going to start off by sharing some data to paint a picture of access to care in our state. Then I will pass it on to our speakers. Next slide. So what you see here, again, focusing our discussion on the PPOR findings and the lack of prenatal care and how much of an impact that can have in preventing excess mortality, infant mortality. We see here, just looking strictly at no prenatal care, on average, we had around 1,700 live births per year that do not have prenatal care. This is approximately 2.05% of births, which is around 1 in every 40 in Arizona. The chart on your right, what you'll see there on the bar are the number of live births with no prenatal care. And then the maroon purplish line is the percentage of births with no prenatal care. And so you can definitely notice that we have been on the increase when it comes to no prenatal care, with the exception of 2019. Again, this is pre-COVID data, and this is all based out of the Arizona birth certificate data. Therefore, the impacts of COVID we'll have to see until that data set is out and available. The annual percentage of live births with no prenatal care has been, for the most part, less than 3%. However, since 2009, the percentage of live births with no prenatal care increased by 44%, with noticeable increases between 2013 and 2017, and a decrease since 2018. Next slide. So when we see at that overall percentage, that orange line there is the 2.6%. Again, that is the percentage of live births with no prenatal care. You can see that when we look at, let's characterize this no prenatal care a little bit more by different demographic groups. By race, you see that American Indians have a higher rate of no prenatal care compared to the state of 2.6. Black and Hispanic mothers also report higher rates of no prenatal care compared to white Asians. When it comes to maternal age, we see that young moms under the age of 19 report much higher rates of no prenatal care compared to the other age groups listed there. Mothers with less than high school education also report a higher rate compared to the other groups. Unmarried mothers, and then those living in a rural setting. Now, a rural setting is defined here. We're using the Bureau of Public Health Statistics definition for rurality, and that is pretty much anybody that lives outside of the Maricopa, Yuma, Pinal, and Pima counties is considered a rural resident. Next slide. When we look at payer of birth, who pays for the birth, we see that self-pay has the highest rate of no prenatal care. Now, this could mean either, again, no insurance, self-pay, which could really be the spectrum of who is paying for this birth. Could be folks that are uninsured, but could also be folks that have the means to pay for their own birth. So that statistic is a little bit, you have both sort of spectrums of payer. However, we see a much higher rate also with when IHS is a payer of birth, reporting no prenatal care at 7.6%, again, compared to that line of 2.6% statewide. Women who report being heavy smokers as well have a higher percentage of no prenatal care. And then low birth weight, as in less than 2,500 grams, has a really not easily ignored rate of no prenatal care at 28.8%. Again, this ties back to our PPOR findings that prenatal care really has a potential to improve maternal and infant health outcomes in our state. Weeks gestation, under 37 weeks was at 7.1%, but over 42 weeks had a higher rate at 10.8%, excuse me. And then if the infant had a NICU admission, we see that there was a higher rate of no prenatal care at 7.7%. Now, the statistic there for medical risk factor is, again, for anything such as pre-gestational diabetes, gestational diabetes, hypertensive disorders, and a gamut of other medical risk factors that the mother may have. And so you see here that compared to the statewide average, there's not much of a difference. So here, the main story here is low birth weight, kind of driving a lot of this disparities. Next slide, please. When we looked at access to maternity care in Arizona, we looked at 3 different categories based out of the March of Dimes Nowhere to Go Maternity Care Deserts Across the U.S. report in 2020. On the left, you see a map of Arizona's counties showing the number of obstetric hospitals or birth centers in the county. And you see that the darker the shade, that means no hospitals or birth centers, with Greenlee, Apache, and La Paz showing no birth hospitals or birth centers. Now, the lighter the shade, the more number of hospitals with birth centers. And so when we look at the map in the center, we see obstetric providers per 10,000 births. Again, the darker the shade means no obstetric providers in that area. And then on the right, the percentage of women 18 to 64 years of age without health insurance. Again, the darker the shade, in this case, the larger the percentage of women with no health insurance. And so these 3 metrics are combined to identify what we know as maternity care deserts, which you will see there that La Paz, Greenlee, and Santa Cruz and Cochise are areas of limited access to maternal care and are significant areas of limited care for moms in our state. Next slide, please. So transitioning over from maternal health to infant health, this is data from the National Survey for Children's Health that is run by the U.S. Census Bureau. We see that in Arizona, 88.5% of children ages 0 to 5 years old, their parents report that their child has excellent or very good health. However, 3 out of every 8 children do not have a personal doctor or nurse, and 3 out of every 8 children do not have a medical home. We also know that close to a third of children do not have usual sources of sick care. When we looked at uninsured children from ages 0 to 5 for that combined year of 2016 to 2019, we see that Arizona has a much higher rate of children who are uninsured compared to the nation at 8.1% versus 5.5%. And then when we were able to look at racial disparities here, we see that more white children have a personal doctor or nurse compared to other racial groups here in Arizona. Unfortunately, due to the limited data availability, we had to combine Black, Indigenous, and Asian into the other category. But showing you that phenomenon again, that communities of color have fewer children have a personal doctor or nurse to seek care to. Next slide, please. Great, so now what we'll do is I'll go ahead and introduce our presenters now that we had that foundational presentation there on the data. So here, now we'll like to take a turn over to our first speaker, Breann Westmore, who is the Director of Advocacy and Government Affairs for Centering Healthcare Institute. Breann is going to tell us about what is happening legislatively, both federally and at the state level, to improve access to care for women and infants in our state. As a reminder, full bios for all of our speakers are located in the platform, in the WOBA platform, if you would like to learn more about those you hear from today. We're also going to hold all questions for the end of the session, but feel free to put them in the Q&A section on Zoom at any point. Welcome, Breann.
Hi, good morning. I'm Breann Westmore, and as Martine graciously said, I'm the Director of Advocacy and Government Affairs for Centering Healthcare Institute, and really excited to kind of just walk through some of the effective state policies and solutions we're seeing across the country in maternal and infant healthcare. First off, just giving a glance over the 2021 legislative session. It was the longest legislative session I have certainly been a part of. It lasted for 171 days. The last 2 months of it were really solely focused on the state budget. For those of us that had bills that went early in session, it really was just a waiting game for us to get to the end of session. It passed in avoidance of the government shutdown. And I also wanted just to indicate how many bills were introduced. Over 1,700 bills were introduced during session and 412 passed. And I only focus that on telling people not to get discouraged. Just because you run a bill one time doesn't necessarily mean it's going to pass. A lot of us have to come back year after year with our different issues. So keep encouraged, keep going to the Capitol, and good things can happen for your bills if we keep advocating. So I want to go over quickly some of the highlights for the 2021 legislative session. Senate Bill 1011, which was a Maternal Mental Health Advisory Committee by Senator Westmore, established a 21-member Maternal Health Advisory Committee that is facilitated by Access to look at screening and treatment around mental health disorders. The committee is required to submit the report back to the governor and the legislator by December of this year. So maternal depression, which includes depression before pregnancy, can have serious consequences for the mother and potentially devastating consequences for the infant. Postpartum depression rates vary by state, and as many as 1 in 5 women can experience postpartum depression in their lifetime. Currently, 37 states allow, require, or recommend that Medicaid cover maternal depression screenings at well child visits. Arizona, at the time of the data was pulled, did not have this policy in place. At least 13 state Medicaid programs cover maternal depression screenings in its entirety, including Colorado, Delaware, Iowa, Illinois, Virginia, Washington, and other states are coming up with state strategic plans clearly only looking at postpartum depression and maternal mental health. For example, Texas just came up and released a state plan focusing on this. So if you want to reference how Texas is doing that, it's a great example that was just released. I just want to talk about some of the possible future legislation and programmatic ideas that if you work in this field and are inspired to continue making change in this area of kind of what I think Arizona may be looking at next. So currently we talked about we don't have a mandatory screening program. That's definitely something that I think we could focus on in the future. Establishing a referral network. So those providers, those OB providers, those midwife providers have a direct link to get patients into services quickly. A state-funded public awareness campaign, access and approved use to telemedicine, and payment and network adequacy reform, meaning that we want all participants who are on a variety of plans to have access to equity level of care in the maternal mental health services they do receive. Senate Bill 1082 allowed pharmacists to dispense hormonal contraceptives over the counter. Contraceptives has been named one of CDC's most leading health advancements of the 20th century. Currently, 17 states allow for pharmacists to prescribe contraceptives over the counter. Now that includes Arizona because of the Senate bill last year. Policies and coverage differ by state. Languages of the law differ by state. Some do not name particular methods, some do. Some require a patch or pill or refer to broader categories as self-administered or not. So again, you've kind of seen one state, and how it does it, but I'm really excited that Arizona did choose to pass this last year. Some of the other nuances that can be considered with that are good policy is only as good as it's implemented. So getting the word out about the ability now for women to receive this over the counter is really what's needed next. And I think there are some great groups in Arizona who are going to be helping to spread that message, but encourage other groups to get involved and really team up and see how we can make this as a big of awareness campaign as possible. We need training for pharmacy staff on the implicit bias of prescribing over the counter, types of birth control options for different individuals, and could some states actually include domestic violence screenings and trainings for the pharmacists that may see these women approaching over the counter. We should also be looking at types of contraceptives that insurance plan will cover with and without prescription, and also address quality limits in what they can get over the counter. We know transportation is often a barrier in rural counties, and being able to get a 90-day supply over the counter is much easier for individuals to access that care than having to go every 30 days. Senate Bill 1181, which was allowing the creation of a voluntary certification program for doulas. So this is being housed within ADHS, and doulas, making a level set, are non-clinical professionals who provide physical, emotional support to mothers before, during, and after childbirth, and during that continuous labor process. Doula-assisted mothers are 4 times as likely to not have a low birth weight baby, 2 times as likely to not experience birth complications, significantly more likely to initiate breastfeeding. There's a lot of data out there on the benefits of doula, so it's really exciting that Arizona has taken this into creating the certification program. Ultimately, where states use this is they go for Medicaid coverage of doula services for individuals. Doula care is important, yet it's underutilized and often not understood in the way that the care is provided into the benefits to both mom and baby. It allows for improving of health equity and being able to help ensure customs and traditions that are important to that mother during birth. Community-based doula programs hold significant value for Black and Indigenous communities, and really excited that ADHS has taken the lead on looking into our Indigenous populations and doula programs. Some of what we can look at as far as future legislation would be, again, Medicaid's coverage of doula care, looking at other insurances allowing for doula care, requiring the managed care plans to cover these services, and also provide that level of equity training for coverage and for support of that mom. Support training and workforce development for doulas. We need to be able to have sustainable programs to train up the workforce to cover as many births as we have in Arizona. We have around 80,000 births a year. About 50% of those, if not greater, are to moms on Medicaid. So being able to train up the workforce, have quality programs that individuals can become licensed and doula trained out of is really important. And as we saw in the pandemic, having doulas recognized as an essential first support system. So hospitals during the pandemic, we saw them lock out doulas from being able to come in to really help support that mom and that family. And so some states such as New York and California did go as far as to recognize doulas as medical support. So Senate Bill 1680, which was the newborn screening program, which is requiring the Department of Health Services to add XALD and SMA to the newborn screening panel by the end of this year, and requiring that they add the continuing other conditions by 2023. This is really exciting for just the equity of birth movement happening across the country. We were one of the few states that did not have a universal newborn screening program. What newborn screening is it's the heel prick screening that's done both in the hospital and out. The first screening is usually done in the hospital within a couple days of life, and the second one is conducted 5 to 10 days after birth. Currently, Arizona screens for 31 out of 35 conditions, and really excited to see this change happening for Arizona and for Arizona babies. Some of the future legislative implications that we can think of are focusing on the quality of the sample and the ability it is to get to the state lab in a timely manner. We worked greatly on a transit time project to ensure that was improved from data that we had several years ago, but I think that's always something that we could look at. And educations on the false positives. Training and funding for the state lab is greatly needed to ensure that our state lab has the equipment that they need to test for these conditions that are coming down the pike from national. And timely access to covered therapeutics. So for these families that get these diagnoses, we want to be able to get them into treatment quickly and not have insurance as a burden to the process. Some of the emerging trends that we're starting to see across the country, and Arizona is just starting to look at paid family leave. In Arizona, even unpaid leave under the FMLA is inaccessible for about 63% of our population. The benefit of paid leave is almost unmeasurable. So if you have had a baby and can imagine going back to work a few days after, it's for some of us overwhelming to even think about, but the reality for many. Providing paid time off and care for newborns is greatly shows the benefits in improving maternal health outcomes and economic stability. Different approaches in cost and eligibility across the states, but I am excited that Arizona is beginning to have that conversation. One of the other emerging trends is group prenatal care. Group prenatal care is an alternative method of prenatal care facilitated by a trained health professional. Usually 8 to 10 women are in a group, and it is about an hour and a half long for the group to meet. The benefit of group care is a woman, a birthing person, receives about 20 hours of prenatal care versus the average of 2 hours if you are seeing a provider one-on-one. Some states, again, across the country have made great strides in implementing group care. 10 states currently offer enhanced reimbursement to providers to implement this model, including California, Georgia, Louisiana, Michigan, Texas, Utah. 8 of these 10 states allow Medicaid to reimburse providers for prenatal care at a higher rate than the traditional and negotiated rate, which we're seeing a lot more states adopt this model, and of course providers using this opportunity to implement this different level and style of care. 2 other states have used grant dollars within their Title V programs to pay for this enhanced reimbursement for providers. In contrast, 16 states do not explicitly promote group care in any way. We're hoping that Arizona will be changing that and not necessarily having to adopt the enhanced reimbursement, but states can also turn on an ICD-10 code to allow providers to report in if they are practicing this level of care in their facility. There are different methods and different programs for group prenatal care. From both Centering has one, March of Dimes has one, and then there are other models across the country that can fit different clinics and different needs. Some of the emerging issues and programmatic ideas that Arizona can adopt is looking at a grant-funded program to be able to help providers implement these types of programs. Working on network adequacy to have physicians who are in all networks being able to offer this level of care. So in Arizona currently, we have about 30 different physician practices that are implementing group care that we know of. We expect that there are more, but because we can't quantify with that claims data, we're just not sure. But looking forward to expanding this in the years to come in Arizona. And postpartum extension. So you've probably heard about this as it is in a lot of federal legislation at the moment, and excited that it is a buzzworthy topic in maternal child health. What this means is the state would have the option to extend the postpartum period from 60 days up to a year. Several state legislators have allocated the state funding needed to implement the new provision and directed their state Medicaid agencies to adopt this option. Again, Medicaid covers almost half of the U.S. births, and this is directly linked to reduction in maternal mortality and infant health. Black women and our Native populations often die at a much higher rate, as you've heard during the presentation, and approximately 30% of pregnancy-related deaths were caused by suicide or overdose in the postpartum period, 43 to 365 days. So really needing to follow that pregnancy at a much longer time than just the 60 days that is current law. So future ideas and really work that is already underway is to urge Medicaid to submit and approve pending Section 1115 waivers, allowing states to change this and move beyond the 60-day period. Locally, there's some great groups that are organizing this effort. Children's Action Alliance is one of those that plans to have an effort at the Capitol in 2022. So if you're interested, I have all of those links and fact sheets available as well. We need help in running the numbers and the cost. There is a cost to this, and being able to work with our legislative leaders and the community to figure out how best we can implement such a change and have patients tell their stories. We really want to hear from people that has impacted and how this change can benefit many in the future. So on the federal level, there is a lot going on. I wanted to highlight probably my favorite and easiest tracker for folks to use, which is AMCHIP. And again, you can sort by any of the topic areas listed in maternal health. It's a great resource. One of the ones that you may have heard about that has gained a lot of traction is the Omnibus Act. And it's a legislative package comprised of 12 bills that address different levels of maternal care. One of those is the Kira Johnson Act, which is addressing inequity in maternal mortality. It's important legislation because it's addressing the social determinants of health and community-based organizations, growing and diversifying the workforce, and improving data collection process, because we need to better understand through the data what's happening to be able to impact our change. Individual bills represent targeted and specific solutions to the maternal health crisis inside of the omnibus. Really looking with a focus of the equity lens and looking at systematic and foundational issues inside of the states. So the federal legislation is quite expansive and could take a whole session to talk about, but I encourage you to check out the AMCHIP tracker. It goes to different fact sheets as well. And other national organizations and nonprofits have fantastic reporting out that you can join listservs to find out more information about the federal efforts. So if any of this was really exciting and you want to take action, some suggestions for what you can do are to call, write, email, schedule a meeting with your members, use social media and reach out to them. And when you do, make sure that you do your homework. Understand that your members' voting history, and you can really bring that into the meeting. And don't forget to make an ask. Ask your legislative leaders what's important, and follow up. A lot of them want to stay in touch once they meet with you regarding an issue. So again, there's a lot of groups in town that have fantastic lobby days at the Capitol and are always looking for passionate community members to support those. I encourage you to get involved with them. And here is just a small snapshot of the resources that are available to you regarding just the topics that I covered today. A lot of these have email listservs and groups that you can join regarding keeping up to date on the current issues. So that is all for me, but I look forward to any questions that you guys have at the end of the presentation.
Great. Thank you very much, Breann, for telling us more about what is happening legislatively, both federally and at the state level, to improve access to care in our state. Next, I would like to introduce Dr. Sara Salek, who has been the Chief Medical Officer for the Arizona Healthcare Containment Cost System, also known as ACCESS, since June 2014. In her current role, Dr. Salek spearheads the agency's major clinical initiatives, as well as oversees the quality and delivery of healthcare services ACCESS provides. Dr. Salek is going to tell us more about ACCESS's role in improving access to care for women and infants in our state. Welcome, Dr. Salek.
Great, thank you so much. Wonderful to be here this morning, and saw a lot of shout outs for Breann as far as all of your advocacy work and great presentation. I'm happy to carry the baton here and provide a little bit more detail around our Arizona Medicaid program, otherwise known as ACCESS. And so without further ado, one fact that I like to share is that Medicaid has a huge impact in regard to maternal child health. And we're actually the largest single payer for maternity care in the United States. And in Arizona, we're actually covering over half the births. So when we're talking about maternal child health outcomes, play a pivotal role in regards to the delivery of healthcare services and being the primary payer of those healthcare services. Additionally, wanted to note that nearly 2 out of 3 adult women enrolled in Medicaid are in their reproductive years. And so again, speaks to the importance and the footprint that we have within Medicaid to serve women and their children. And then, the most, pivotal issue here is ultimately impacting the maternal and child health outcomes. We've heard a lot this morning in regard to disparity and in specifically our indigenous population, as well as our, African-American women. And so we have to continue to do a better job in improving access to care for all women, and in particular, address those healthcare disparities. All right, so this actually is a graph of from CMS, which is the Center for Medicare and Medicaid Services. It's our primary funder of Medicaid. And as you can see, this is a percentage of live births paid for by Medicaid by state. and the dark blue is on the higher end. And so as you can see, Arizona, New Mexico, some of the other southern states are in that higher range. And I had mentioned that currently Medicaid in Arizona pays for over half of the births, and that's represented here. This graphic is on the DHS website, as well as in their maternal mortality review report. It speaks to the different factors that affect both maternal mortality as well as morbidity. And those 4 factors include system factors, which is around health insurance coverage. So the cornerstone of Medicaid, which is part of the Social Security Act of 1965, was really to provide for pregnant women and their children. And so it is such a foundational aspect of health insurance coverage in America, specifically targeting pregnant women and their children. And so we are very fortunate and need to continue to foster access to care through Medicaid and through the programs that we offer. And so as far as access Medicaid eligibility, we do have a specific pregnancy category. As you can see on this slide, there are specific requirements, including being an Arizona resident, being pregnant, being a United States citizen or a qualified immigrant, et cetera. And so if you want more information around the pregnancy eligibility category, there is a direct link here to our website. I also wanted to note that we have specific Medicaid medical policy standards. And so it comes through what we refer to as our Access Medical Policy Manual, AMPM. And there's also a hyperlink here in regard to our Chapter 400. And some highlights of our maternity care standards include that we don't reinvent the wheel. We follow ACOG standards for OBGYN services. We reimburse for licensed midwives within their scope of practice, and we have specific details in this policy. We also note that all inductions and C-sections done prior to 39 weeks follow the ACOG guidelines. So again, wanting to address, and improve healthcare outcomes for women, including addressing preterm deliveries. As far as the covered benefit, it is a very rich benefit. We basically we provide for all medically necessary and reimburse for all medically necessary services for pregnant women, including transportation. So we talk about social determinants of health, issues in regards to, Martin had mentioned around maternity care deserts. And so that is one thing I wanted to note, is that we do reimburse for non-emergency medical transportation, so that transportation is not an issue for our members. We also have specific network standards for our managed care organizations. Arizona Medicaid has been mandatory managed care since the inception of our 1115 waiver in 1982. And so the vast majority of healthcare services provided to our pregnant women are through our health plans. These are the current standards within our current contractor manual. And so for OBGYNs, the requirement for our managed care organizations are to have, for Maricopa and Pima County, 90% of the membership does not need to travel more than 45 minutes or 30 miles from their residence. And again, just want to note that we do cover transportation. The other is that for all other counties, 90% of the membership does not need to travel more than 90 minutes or 75 miles from their residence. And the time and distance for these providers is measured using basically female members between the age of 15 and 45 years of age. We also have standards within our contractor manual for initial prenatal care appointments for first trimester through third trimester, as well as requirements for high-risk pregnancies. Wanted to note, so as far as the Department of Health Services Advisory Committee on Maternal Fatalities and Morbidities, this is a specific graphic within the report that is hyperlinked below that puts access in comparison to some of the other health plans, including private insurance, IHS, self-pay, other government, and unknown. And so you can see as far as severe maternal morbidity rate per 10,000 delivery hospitalizations, that access is at 138.2. And so definitely have some room to improve in regards to getting below that 119 and even beyond. So it does describe where we're at and that we have some room to improve here. Other aspects in regards to measuring how we're doing within Arizona Medicaid when it comes to maternal and perinatal outcomes are developed by the Centers for Medicare and Medicaid Services, and specifically we have what's referred to as our child core set and adult core sets. And as you can see right below that, there are specific performance measures that we monitor and that the federal government monitors in regards to how we're doing as a healthcare system and a Medicaid system delivering services to our members. And so the ones that are that have the audiological diagnosis no later than 3 months of age, as well as elective delivery, are actually being proposed for removal from the child and adult core sets based off of the advisory committees to CMS. So I did want to make that note as well. This is a graphic showing how Arizona is doing in comparison to the rest of the states in regards to percentage of low birth weight, less than 2,500 grams by state. And these are births specifically paid by Medicaid. And this is the most recent information available, which is from 2018. And lower rates of percentage of low birth weight are better. And some good news to share in regards to we are in the dark blue, which is the lower rate. And so something, you know, for us to celebrate, although again, we can always strive to do better. I also wanted to show how Arizona is doing in regard to percentage of preterm, less than 37 weeks births by state. And these are, again, births paid for by Medicaid, and lower rates are better. And Arizona is in that lower rate in that dark blue line in the 8.7 to 10.2%. So again, we want to be in that lower number, and we're amongst the darker blue states that are. So that is some good news to share as well. And then last but not least, this looks at specifically the number of OBGYNs as well as advanced practice midwives per 100,000 reproductive age women from 2017 to 2018. And so as you can see on this graphic, we're in that light aqua color. And so definitely issues, and as Martine had mentioned earlier, around the need to continue to address access to care to OBGYNs and midwives. And I know Edith is going to be talking a little bit more around what Department of Health Services is doing to expand that access through their programs. A few more items that I wanted to share is in regard to additional funding coming from the federal government as part of the American Rescue Plan Act. And it is what we had discussed previously around Breann mentioning that 12 months postpartum coverage. So it is on Access's to-do list, and it's something that we're actively engaging with policy policymakers in regard to the funding mechanisms and the approval to make that happen. And so stay tuned in regard to the next legislative session that's coming up in 2022 as far as discussions there, as well as requests to the federal government in order to make that happen. We also have specific grants targeting our members that have severe mental illness, SMI, as well as substance use. And among our grants include our state opioid response grant, and we have specific projects specifically aimed at pregnant women who have substance-based conditions, including opioid addiction. And we also have our substance abuse block grant that prioritizes pregnant women with substance use conditions. So did want to make note that it is amongst our priority to address maternal morbidity and mortality, to address the co-occurring mental health as well as substance use disorder needs. This is one other example of a grant that we have. It's our state pilot grant program for treatment of pregnant and postpartum women, PPW PLT. And in that we have a learning collaborative as well as workforce training, and Kodak Behavioral Health through Arizona Complete Health is directly providing services to pregnant and postpartum women through this grant. Last but not least, we have in this last legislative session, as Breann mentioned, we've got our Maternal Mental Health Advisory Committee. And so that is actually what Access is going to be spearheading. And we're in the process right now of identifying committee participations of specific members. It is established to recommend improvement for screening and treatment. And I see a lot of great recommendations coming through the chat box from you all. It's going to be composed of maternal as well as mental health experts across the healthcare system, and there's recommendations due to the legislature in December of 2022. So we have just over a year to come up with recommendations around how to improve maternal mental health in the state of Arizona. And with that, I will turn it over to Martin and Edith.
Great, thank you so much, Dr. Salek, for helping us understand Access's role in improving access to care for women and infants in our state. I think it's a really great presentation, especially hearing what is coming up down from the feds when it comes to the American Rescue Act and increasing that coverage up to 1 year postpartum. So that's good to hear. Great, so next, I'd like to introduce our last speaker for this session, Edith Di Santo, who is the chief for the Primary Care Office in the Bureau of Women and Children's Health. The Primary Care Office oversees workforce programs aimed at increasing access to primary care and other services with emphasis on the health needs of underserved people in areas. Edith is going to share about what ADHS is doing to improve access to care in our state, particularly through provider recruitment. Welcome, Edith.
Thanks, Martin. So like Martin said, I'm the Primary Care Office Chief for the Primary Care Office. So I'm going to talk a little bit about the access to care initiatives. Oh, there they are. Okay, so quickly I wanted to go over some of the things that our office does. So like Martin said, is the emphasis of our office is to strengthen systems and expand access to care, especially in underserved areas, underserved people in underserved areas. So some of the goals is to strengthen the system and then increase the number of providers. So one of the main goals is to increase the number of providers and evaluate the access to care throughout the state. So one of the things that our office does is we assist with data collection evaluation of the shortage designation, the health professional shortage designations, the HIPSAs, and we work on those to submit to HRSA to get for our state. And then we provide technical assistance for statewide partners for federal and state programs. So overall, we administer in-house the evaluation and data collection for the HIPSAs, the Health Professional Shortage Areas of Arizona, and then the medically underserved areas or populations. And then we also review sliding fee schedule and, put out a map on our website for people to access to see where to go to get access to care, where there's clinics providing sliding fee scale. We administer the Arizona specific state loan repayment program, and we also administer the J1 visa program and the National Interest Waiver program. We also provide technical assistance for the National Health Service Corps for both loan repayment and scholarships and site eligibility for both National Health Service Corps and the Nurse Corps. So just a little bit of an overview of the shortage designation. So there can be 3 types of shortage designations by HIPSA. So it can be a geographic area, a population, or a facility that has a shortage of health professionals. And there's 2 types. So there's either the health professional shortage area, a HIPSA, or it can be a medically underserved area. So for medically underserved area, it's only primary care, and it's related to the geographic area or a population group. But for HIPSAs, there's 3 types. So it can be a primary care, which is providers, and then mental health services or dental health. So there's 3 types of HIPSAs, and any area can either have a primary care, mental, and dental health, or it can have 1 of 3 or 2 of 3. And there's also a facility HIPSA. So all community health centers typically have a facility health HIPSA as well. So this is a map of the primary care HIPSAs. So similar to the maps that you've seen before, the darker the red, the more needs and the higher HIPSA. So the higher HIPSA means the higher need areas. And so this is the map for primary care. And you can see that in rural areas, there is, higher need. But even in Metro Phoenix and Metro Tucson, there is pockets in areas that have high needs as well, and have high HIPSA scores. And then for dental, we can see it as well. It's a little bit more red throughout the state, and also in Metro and Metro Phoenix and Metro Tucson. And then we have the mental health HIPSA as well. So it increases between mental and dental health areas for HIPSAs. So this is kind of the evaluation. So we submit data to HRSA, and then they, designate the areas. So for primary care, there is currently 220 HIPSAs. And to get rid of those HIPSAs, we would need 559 primary care physicians throughout the state of Arizona. And for dental HIPSAs, there's 211, and we would need 382 dentists throughout the state of Arizona. And then for mental health, we have 213 HIPSAs, and we would need 182 psychiatrists throughout the state of Arizona to address those. So we do have a lot of HIPSAs and a lot of need in Arizona. So the HIPSA is designated through HRSA. We submit everything to HRSA, and then they designate a score for each of the areas. And this is a tool where HRSA and the state of Arizona use this to qualify for funding preferences for awards, both for federal and state programs, the level of amount of award to the provider, and also like other grant opportunities to health centers and different organizations applying for funding from the government, and then scholar placement. So HIPSAs are really important throughout the state of Arizona, and in any programs to get funding. So one of the main programs that we administer through my office here at the primary care office is the Arizona State Loan Repayment Program. And this program is to provide an incentive to recruit and retain providers in underserved areas, both rural and, underserved metropolitan areas as well. And then we want to increase providers and thus increasing access to care in these areas. And this program is modeled after the NHSC federal program as well. So we have an external survey that, surveys providers before, in the middle, and after their state loan repayment commitment of 2 years. And we can see that, providers anticipate that they'll stay in their current practice an additional 9.8 years. So we do see that these state loan repayment programs are a good retention tool. In rural practice, up to 14 years. So we do want to support these providers and give them these incentives, because it seems like they do want to stay in their communities once they experience it. So I'm just going to give a little bit of detail about the requirements of the program. So, you can help us recruit and get the word out there for providers, because this is one tool to get providers into the rural areas and in the underserved communities where we sell those health deserts, where access to care is an issue. So we want as many people to know about it so we can place providers in these different areas. So the disciplines are physicians, and they have to be primary care. So they can be family medicine, OBGYN, pediatrics, internal medicine, and geriatrics and psychiatry. And then we have dentists, pharmacists, and then advanced care providers like physician assistants, nurse practitioners, and certified nurse midwives. And then we have, for behavioral health providers, they can be licensed clinical social worker, a licensed family and marriage therapist, a licensed psychologist, and a licensed professional counselor. So those are the eligible disciplines we have currently. And then depending on if your service is full-time or half-time, this is the awards based on a full-time commitment. So the higher the HIPSA, the higher the award. So physicians and dentists can get up to $65,000 for 2 years of service in the state loan repayment program for Arizona. And then all other providers can get up to $50,000 for 2 years of service with the highest HIPSA score of 18 to 26. And these awards are taxes exempt. So it's really a big award and a big benefit, because we know, as we know, a lot of providers come out of school with a lot of debt. So this is a good incentive to get providers into underserved areas. So these are some of the ways that we prioritize who gets funding for these programs. So if it's a rural versus urban, they get points for each of these, and some of them are weighted higher than others, and rural is one of the ones that we weigh specifically pretty high. The HIPSA score, so depending on what HRSA has assigned their area or their facility as a HIPSA, that score, the percentage of underserved populations served by the site. So we give more points for the more underserved that are served at their site. What's the next closest sliding fee scale with a similar service? So how much access is near them. So the less access, the more points they get. If they're new to their service site, if they provide on-site service versus telemedicine, we give points. We do provide some points for Arizona. So we want to, keep people who want to be in Arizona in this program. We do give points for Arizona, being an Arizona resident or being a graduate of an Arizona graduate system. So if they went to med school or their advanced degree is in Arizona, they do get extra points. And then if they had past experience serving in a medically underserved area, that's also gets points. And then full-time versus half-time, we give those points. So this is how providers are scored. And so our cycle is, every year in March, January through March, sites must register to be active for the next state loan repayment year. So if you have any sites, have them reach out to me and we can get them ready to register for next year. And then in April, we have the renewal cycle for anybody who's already served 2 years, but then the initial cycle when any new provider who wants to join the program is the application is due in June. So applications open in mid-April. So through June 1st, they can apply. And then in October is when we typically give awards and contracts are started for the applicants. So Arizona was recognized nationally for their state loan repayment program because we were able to increase diversification of funds. So typically the funds that we get from the federal government for the state loan repayment program have to be matched by the state. So I think in 2006, there was only 250,000 for this program, and now it's increased for the state match is, from the federal match is $1 million. So we have to have a state match of at least $1 million, and now the program has grown to over $2 million. So of state funding plus the federal funding. So we have been able to increase our budget and increase the amount of providers we have on this program and throughout the state of Arizona. So currently we have about over 150 providers, and we expect that this year we've increased the number of providers. So we'll probably have more in the program starting October. So we want to make sure we have outreach efforts throughout the state, and so I'm open to having people reach out to me to have presentations to your organizations or to anybody who you think might benefit from this program. So we typically outreach to medical, dental, and health services schools in Arizona, and we do conferences and professional organizations, so feel free. Another thing that, given there's so much American Rescue funds available, organizations can donate to the program as well to support the program. And if your organization wants to donate to the program, they can be earmarked specifically for a discipline or for a county. So feel free to reach out to me. My contact information is there. So that's a state loan repayment program. The J1 program is another program that we do to increase workforce and access to care throughout the state. So we act as an interested party to support up to 30 providers a year. So these are physicians or specialists who commit to serving in the state of Arizona for at least 3 years. So we go through the application process and we write support letters for these physicians, and then we make sure they complete their 3 years of service for the J1 program. So the J1 program also increases providers in the state of Arizona. And then as a continuum of the J1 program, we also have the National Interest Waiver, the NIW program, which also ensures that helps providers stay in the state of Arizona after they've worked in the J1 program to continue to work and support our healthcare system in the state of Arizona. I also want to share a little bit about what our Bureau is doing. This isn't within my office, but the Office of Women's Health is supporting the Doula program. So the AZ Health Start program has added since 2015 the doula option, and community health workers can get a certification and training to be a certified doula through these organizations. Currently, 2 contractors provide this option, and over 100 women have received services since 2015. So like Breann mentioned earlier, the Arizona State Bill of 1181 was passed this legislative session. So it charges Arizona, the Department of Health Services, to create a Doula Community Advisory Committee and the rules for the voluntary certification of doulas. So the AZ Maternal Innovation Program is partnered with indigenous communities statewide to create a training series. And during this series, the doulas were provided training opportunities such as the cradle board, the moss bag, massage during labor and delivery, and birth support during COVID-19. So these are some of the initiatives that our Office of Women's Health is doing. And then they also partnered with the maternal health task force, suggested that the doulas be trained in perinatal mental health. So this was an opportunity for them to become certified in perinatal mental health. So these are some of the other things that, throughout the Bureau and the Division of Prevention that are being done to support that. But other than that, that's my presentations, and welcome any questions. I'll give it back to Martin.
Great. Well, thank you very much to all of our speakers. Those are wonderful presentations on to how things connect both at the state and federal level, and including locals. So now we'll take some questions from the group. There's been quite a lot of questions being brought up in the chat. So I just want to remind folks kindly that we might not have time to get to all of them, but we will do our best. So I will practice my moderating skills in picking the most big question and then try to kind of go through them as we go. So, but because I am the moderator, I could pick which question to go first. So I'll pick my own question to start off of. And so there was a question posed on, do we know if prenatal care is reported for home births that transfer to a hospital? I wonder about the self-pay number. So this data is from the birth certificate. So, if the home birth were to happen, they still need to get, it's still required to have that birth certificate. And so that data is recorded there in terms of prenatal care. Now, the difference is that when it comes to home birth, sometimes that birth is self-reported, the prenatal care, versus in a medical facility where there are EMR records to kind of verify that prenatal care visits. So that's the difference there. I'm going to go ahead and pick a question for each of our guests, and then we'll just kind of circle around. But for Breann, so a question that we had was, can you speak about the Omnibus bill, and how can we advocate for passage of this bill?
Sure. So the Omnibus is the one I referenced that has 12 bills within it. And so each of those bills needs its own advocacy, and they've lumped it into that omnibus bill, which is helpful for discussion and awareness. I would encourage anybody who wants to get involved to look at the bill and look at the organizations that are sponsoring the bill, and then reach out to those different groups. For example, I know March of Dimes does have a advocacy network you can sign up for, and many of the others, March for Moms. So you can see who's supporting the bills when you go online and look it up. And I would encourage them to go to those organizations and sign up for those listservs, as well as reach out to your own congressional members here and Senate members and let them know that you support that.
Thank you, Breann. For Dr. Salek, I think this is I can combine these two into one. So the first part of it is, do the stats that you presented include federal emergency services coverage for births? That's one question. And then the other one is, where can we find the manual?
Yeah, great question. So I will put the hyperlink to our Access Contractor Manual in the chat box in just a minute, so you'll all have access to it. I'll also make sure there's a hyperlink in the actual presentation as well. And then as far as the Federal Emergency Services Program, great question, because we do cover births for our Federal Emergency Services members. And so my understanding, because that is paid for by Medicaid, that it would be included. I don't know if the specifications are on the CMS document where that information was published, but I can, while we're answering other questions, I can go and confirm, but my understanding is because it is paid for by Medicaid that it would be included, but would need to confirm that.
Great, thank you. For Edith, there seems to be quite a lot of questions regarding eligibility of certain or inclusion of certain practices. So I'm going to try to combine all of them in a list for you. So does the loan repayment program include nurse practitioners too, or just physicians? And then somebody else says, why not also include psychiatric mental health nurse practitioners and therapists to fill the mental health HIPSA needs? Why only psychiatrists?
So for the first question, nurse practitioners are included, and nurse psych is also included. So nurse practitioner psychs, the nurse core, like registered nurses don't meet the qualification because they're not advanced care currently, according to the, Arizona administrative rules. But nurse practitioners most definitely are. The data regarding the HIPSAs, and when I said the psychiatrists are needed to meet that, it's because currently the way that HRSA takes the data for HIPSAs, it only includes psychiatrists. It doesn't include nurse practitioners in those fields. So all the data for HIPSAs includes physicians for primary care, and then psychiatrists for mental health. It doesn't include nurse practitioners. We are aware, and the SLRP program does support nurse practitioners to be part of the program, but currently the way HRSA takes the data to evaluate the HIPSAs, it doesn't include nurse practitioner data, even though we know it's an important part of providing care, but it's not part of the evaluation that's taken into the data for HIPSAs.
Great, thank you. So now we're going to circle back to Breann. Breann, folks were interested in knowing a little bit more about the group prenatal care. And if you had any information specifically of who are those providers that are offering that kind of care in Maricopa and Pinal counties.
Sure. So inside of the app website, there are some other resources that talk about group prenatal care and access, and I can absolutely share more with Martin and team. As far as to who is doing it, you can find that out through the different organizations that are administrators of it. Centering has some, March for Dimes has some, then there's other programs out there, and they would be able to know who's using their product, but we're hopefully the access can turn on the ICD-10 code for group care, even if it doesn't have an enhanced reimbursement, then that would allow the state to do an overall data query of how many providers are using this, because we do think there's several out there that are doing it that we just don't know about it. They could have used a program that they self-created, or they got one of the ones that is less known, and so we don't know to reach out to those practices to be able to ask how their group care experience is going. So again, check out the references that I've listed, and maybe Dr. Salek or Martin has other suggestions as far as how to query those practices that are actually doing it.
Great. I don't have necessarily a response to that, but I'll make it available for Dr. Salek if you happen to know from an access standpoint.
And do you mind, Martin? So as far as the specific group type?
Yeah, who's providing group prenatal care, if you're aware?
Yeah, so then it goes back to how we're defining group prenatal care. And so ultimately, if there are specific CPT or HCPC codes, or as Breann said, specific ICD, then we could pull it that way. So I think it's just a matter of the devil's in the detail in regard to which specific codes, and then we can absolutely run a query.
Great. Okay, for Dr. Salek then, here regarding the doula voluntary certification rules. So once the rules are completed and the program is up and running, what is the pathway and potential timeline for access reimbursement for doula services?
Yeah, great question. And so we're currently evaluating that at Access right now, including kind of the path forward from a state plan amendment as well as a waiver perspective. So we're evaluating that And then ultimately, as part of our routine process, we would also do a fiscal review and estimate and share that with the legislature if requested, because if we add additional coverage, including of doulas, then we would have to put forward the state match in order to pull down those federal dollars. And so I don't have a specific timeline yet, but we are meeting as a team at Access to review all the recent legislation from this last legislative session. So I should have an update within the next month or so around timeline.
Great, thank you. For Edith, what surveys have been used or validated that allow us to understand why providers are not locating their practices to the HIPSA or rural areas?
So currently, I'm not aware of any surveys that we've done, but I think that's a great question to take into consideration and evaluate. And I think in this next year, we're planning to do more data collection on providers and their preferences. So I think that's a really great idea. But currently, I'm not aware of anything that we're doing to see why they're not going to those areas. But thank you for that.
Or on the flip side, of course, like what motivated the providers to, the ones that you do have there to be in those areas, for sure.
Yeah, the data that we do have is collected for, so I'm sorry, maybe I misunderstood the question. Is it that providers take their practices or that they decide to practice in those areas?
So it says why providers are not locating their practices to the HIPSA or rural areas.
Okay, yeah, I think that's a great question, and I don't think we do that evaluation, but I think that's something that we could do moving forward.
Great. I think final question for Breann. We're doing very well on timing. When our mothers are only seen 1 to 2 times normally in the postpartum period, would a mental health screening program utilizing our pediatricians be advisable? Or is Arizona changing our requirements to increase postpartum coverage visits for all moms?
I think that's a multi-pronged question. So yes, there are states that cover screening and their EPSDT visits in that first pediatric appointment. So there are states that have looked to doing it that way. That comes with a lot of rules and working through because mom isn't the pediatrician's patient. And so there's really strong referral networks that have to be in place. And that's absolutely a solution that I think Arizona could look into. Also, again, coming up with a recommended comprehensive screening analysis. We know that there are evidence-based screenings out there and looking to recommend using one of those best practice methods. And then Martina, am I forgetting part of the question?
So you said, or is Arizona changing our requirements to increase postpartum coverage visits for all moms?
So there is the effort underway that I talked about, being able to extend the postpartum period up to 1 year from the current 60 days, and Dr. Salek could speak on it as well. That would then give coverage to those families that are not already covered by Medicaid and are in that SOBRA category that we call in Arizona, SOBRA, that extended category. So that would in fact give them coverage, and that would include the mental health services as well.
Great, thank you. And on the other side, from the maternal mortality standpoint, we do know that a lot of our maternal deaths happened in the postpartum period. And we cite being one of those lack of coverage as one of those barriers for these women. So very much needed. So Dr. Salek, this is a long one, so I'm going to pace myself with it. Currently, no Arizona hospitals are able to staff according to the Association of Women's Health Obstetric and Neonatal Nurses, or A1, guidelines due to reimbursement to the hospitals. In early 2022, these guidelines will become standards as we have excellent evidence that these staffing standards make a difference in outcomes. What can we do to influence reimbursement to a level that we can provide care that makes a difference to our moms and babies?
Yeah, so, I always expect reimbursement questions since we're a major payer of services, so I appreciate that question. I think what would be helpful is for me to get more detail around your concerns. I'm guessing you've had an opportunity to speak with my team, including Dr. Tack, and I can definitely circle back around to him. But we would, our standard work, our standard process within Access is we would bring in our reimbursement team to do an analysis. We would look at the fiscal impact to determine if we have the funding available to make that change. And so happy to get more details from you in regard to your concerns. But yeah, this is understandable in regards to as a major payer of healthcare services, we get questions around reimbursement rates on a regular basis, and happy to go more into detail with you on that.
Great, thank you. And I think this is a combo for both Dr. Salek and Edith. Does Access recognize perinatal mental health practitioners as a specialist category, different than generalized depression or anxiety mental health providers? And if not, what would it take to get perinatal mental health recognized as essential specialized care?
Yeah, so I'm happy to kind of first, Edith, take a stab at this. So ultimately, we register different types of providers, whether that be physicians, social workers, psychologists, et cetera. So I would need to know more around this specific designation. Wanted to note that ultimately, and that would be a follow-up question around for this specialty, perinatal mental health. As far as the certification, that could go into kind of the credentialing process with our health plans in regard to additional certification demonstrating, competency to serve a specific subset of our population. So I would need, similar to my last answer, I would need a little bit more detail around what type of providers can be certified with this specialty.
For the state loan repayment program, if the provider is, one of the provider types, and it's in mental health, it would, if their HIPSA was in a mental health facility or a mental health HIPSA, then they, would be qualified to be part of the program under mental health. For specialties, I think the only specialties, that aren't for primary care, we do want to have specialties that serve primary care, and as long as they're not in an outpatient facility, they would be eligible for mental health if they meet the requirements of provider type, if they're a physician, nurse practitioner, or any of the other advanced care provider types. So I think the specialty wouldn't preclude them from being part of it if they meet the mental health requirement. But I'm not too aware, if this is a new designation. So as long as they would meet the requirement, they could be part of it under mental health as a specialty. And then for our J1 providers, specialties are allowed, so they would be able to be part of that program as well.
Thank you, Edith. And so now with a little bit less, almost a minute left to go. Well, this is a short one for Dr. Salek again. There is a question about access coverage for lactation services. They mentioned specifically outside of WIC. Now, WIC is within the Arizona Department of Health Services. So maybe we can just state what does access cover in terms of lactation services?
Yeah, so that's part of the bundle, both, that prenatal postpartum bundle. And so it would be included in that. And so that would be the lactation benefit, because we do bundle pregnancy services.
Great. So I think we are at time now. So I do want to recognize that we had quite a lot of questions coming in. So what we'll do is we'll circle back with the speakers and see if there's a way we can get some responses to your questions there. There were quite a lot. So again, thank you to our speakers for their time and their support to the summit. Great information from all aspects being presented. And thanks to all of you for participating in this session focused on improving access to care in women and children in our state. This was just one small response to the PPOR data that Stephanie shared about access to prenatal care being a risk factor for infant mortality. We know that access to care impacts so many parts of a person's health, even beyond the prenatal period, which is why it's so important for us to consider. So now we're going to be breaking for lunch. However, I realizing and acknowledging that we just presented a lot of data to you all, and that it could be very dense and at times very difficult to sift through. We hope that you enjoy a self-care session that is provided by Felicia Cotosin Ruiz with Kitchen Curandera, which will start right at 12:30. I'm very interested in attending that for sure. And then at 1 o'clock, we will begin the importance of preconception and interconception care, our maternal and infant health outcome session. So please join us at 12:30 again for that self-care session on Kitchen Curandera. And then we will promptly start at 1 p.m. with the rest of our sessions today. Thank you very much. Gracias.